welcome. My name is Suzanne Butler and I'm the Program Delivery Lead at Injury Matters, and I'd really like to welcome you all for here today for our Falls Forum Promoting Independence and Confidence. As I said, we've got people in the room and hopefully we will have people joining us online, but the event today is recorded. Injury Matters acknowledges the Whadjuck Noongar people as the traditional custodians of the land on which we meet today. We recognise their deep connection to land, waters and community, which has continued for thousands of years. We pay our respects to elders past, present and emerging and extend that respect to all Aboriginal and Torres Strait Islander peoples attending this forum. Injury Matters is committed to reconciliation and to walking alongside our First Nations communities, honouring their knowledge and cultural practices in our journey towards safer, healthier lives for all West Australians. And our Reconciliation Action Plan is available on our website. Injury Matters is the leading injury prevention and recovery organisation in Western Australia, and our mission is to help people recover from injuries and, even better, to prevent those injuries from happening in the first place. We work across the state delivering innovative programs and solutions that empower not only individuals but also organisations and policymakers. Our goal is to support the WA community in making informed, safer choices that help reduce the incidence and impact of injuries. Through our programs, we aim to build safer environments and support the wellbeing of people of all ages. We have 3 flagship programs, so Stay on Your Feet, which I will provide some more information on as we go. Our Road Trauma Support WA program, which provides information, support and specialised trauma counselling services for people affected by road crashes and no referral is required. And our No Injury program, which provides knowledge, training, education, resources and networking opportunities for health professionals, local governments, not-for-profits and community organisations to prevent injuries in WA. So Stay on Your Feet is WA's leading falls prevention program for older people living in the WA community, and we are supported by the WA Department of Health, who provides the funding for the Stay on Your Feet program. The program aims to reduce falls and falls-related injuries while encouraging confidence in independent living. So falls in Australia. So I just wanted to give a brief overview of falls as an issue to set the scene. So falls are the leading cause of injury, hospitalisation and death in Australia, with 43% of injury hospitalisations and 42% of injury-related deaths caused by falls. The story is pretty consistent in Western Australia. So falls are the leading cause of injury hospitalisation in WA, and it's important that I note right from the start that this report includes the latest data. However, like a lot of data sets, there's a bit of a lag in the data. So all references to fatality data are from the 2021 calendar year, and the hospitalisation and emergency department data is from 2022. So the 2024 WA Falls report, which is published by Injury Matters, highlights that in WA someone dies every 17 hours because of a fall, is hospitalised every 12 minutes because of a fall, and presents to the emergency department is hospitalised every 16 minutes and is presents to an emergency department every 12 minutes. So this is the 6th edition of our Falls report. So we're able to present some really good trend data. So over the 5 years from 2018 to 2022, there was a 31% increase in the number of falls hospitalisations among people aged over 65. For consistently, the Kimberley has experienced the highest rate of falls from 2018 to 2022, and in 2022 the falls hospitalisation costs an estimate of $313,627,000. All of you will have this information in your pack. You'll have the 2024 WA Falls report at a glance sheet that highlights the stats that I've just provided. And if you would like to look at the full Falls report, you can use the QR code there, or it's on the Injury Matters website. So Injury Matters runs 2 campaigns each year through the Stay on Your Feet program. So each campaign focuses on modifiable risk factors to prevent falls and promotes the Move Your Body, Improve Your Health and Remove Hazards messages for older adults who live in the community, their families and carers and health professionals. Each campaign consists of a variety of activities throughout Western Australia, including training for health and community workers, local community events for older adults, resource development, community grants, and advertising on television and social media. From September to November, so currently, we're running the Improve Your Health campaign. The Improve Your Health campaign toolkit is available on our website, and it contains information and resources to support activities in WA. So whether that's as simple as posting on social media, an email signature, or resources and information to plan a community event, you can find all of that within our campaign toolkits. So information on campaigns and activities are also available on our website, or you can sign up to our Falls Prevention e-news for health and community workers. And we also have a News and Views e-news for older adults. At the moment, we have our grants open for our Remove Hazards grants. So these are for activities that will be conducted in our Remove Hazards campaign from March to May 2025. The grants now close on Friday the 8th of November, so there's not a lot of time. But if you'd like to speak to one of us about what that might entail, our website has a huge amount of information to support a grant application, including ideas of the types of activities that would be considered for funding. So again, I'd like to welcome you to our Falls Forum. Today, our focus is on promoting independence and confidence. Falls can significantly impact the quality of life and confidence, restricting the ability of older adults to stay active and engaged in their communities. By working to prevent falls, we not only support their personal independence, but also help ease the related demands on our healthcare system. Independence and confidence are essential for effective falls prevention because they directly impact that quality of life, mental health, and physical wellbeing of older adults. While preventing falls is our top priority, today's forum will also provide skills and information to support adults to safely get up after a fall if it does occur. The World Falls Guidelines, which other presenters will be covering in today's presentations, emphasise a person-centred approach. This means tailoring prevention efforts to each individual's unique needs, experiences, and abilities. If you haven't already, I really encourage you to have a look at the World Falls Guidelines for further insights. And more information will also be given today on the draft National Falls Guidelines as well. So building confidence to support independence for older adults is really critical. The guidelines suggest listening to older adults' concerns, setting achievable goals with them, and incorporating strength and balance exercises to boost their sense of security. By involving them in decision-making and reinforcing their strengths, we can make a significant impact on their confidence in managing falls risk and maintaining their independence. Today, our presenters will offer practical insights, sharing research, evidence, and techniques on safely getting up after a fall, as well as exercises to improve strength and balance. They will also discuss the psychological aspects, including fear of falling, and provide strategies to address it, empowering older adults to live with confidence and independence. Finally, I really want to extend a heartfelt thank you to our speakers today, Alyssa, Marianne, Christy, and Ian, for their dedication to fostering safety and confidence in our community and for their invaluable contributions to today's forum. So the overview today, we'll start off with Dr. Alyssa Burton, and then Marianne, and then Associate Professor Christy Harper and Ian Holbrook. So I'd like to welcome Dr. Alyssa Burton up to present. So Alyssa is an Associate Professor of Healthy Ageing at the Curtin School of Allied Health and co-domain lead of Curtin's Enable Institute Dementia and Ageing domain. Alyssa's research focuses on helping older adults to live independently at home for as long as they choose through healthy ageing strategies. She's a current NHMRC investigator grant holder, which includes a falls prevention trial for people living with mild cognitive impairment in the community and a successful ageing project. She's also a fellow of the Australian Association of Gerontology. Thanks, Alyssa.
Thank you, everyone. And I'd like to thank Injury Matters for inviting me to present today. It's great to have everyone in the room, in particular due to the fact that the recording will be sent out. So thank you so much for turning up. I really appreciate it. I'd firstly like to acknowledge that I'm on Whadjuck Noongar country and pay my respects to elders past, present and emerging. And it's really important to me to have that positive connection, in particular with their elders, because all of my work is around helping older people to live independently for as long as they choose through healthy ageing strategies. So with our First Nations people, it's really important to me as well. So my session today, I'm going to be speaking about a little bit about lift assist. It was something that I first heard about a number of years ago now, actually in the UK with Professor Dawn Skelton. She just keeps coming in and out of my life. It's quite strange. Then I'll be talking a bit about getting up off the ground and some findings that we have from our systematic review, some techniques that we've looked at. We've actually done a biomechanics study and also a short intervention study with home care clients, and then give some practical and evidence-based takeaways that hopefully you can use in your practice. So lift assist, what is this exactly? It's when an older person falls, they're not actually injured, but they can't get up. Now, this probably happens for a number of your patients. They may be living with a spouse, but more than likely the spouse would be the same age as them, and they may be frail, and so they actually can't help them up either. And so what happens is an ambulance needs to be called. The ambulance comes, they do a brilliant job, they help Mrs. Smith into the chair, they check that Mrs. Smith is going really, really well and that she's okay, she's not injured, she'll do all right, and then they leave. No referral, not necessarily some suggestions on what she could do, where she could go, how she could cope with this next time if it happens. And so I know Injury Matters have been working a lot with St. John's to try and assist in this process, to try and get those referrals happening. But a lot of the time it's just this never-ending cycle. So some of the data that we've looked at over the last sort of decade and a half, New South Wales, about 5% of their call-outs for ambulances are to do with falls. And for that 5% of falls calls, 24% was actually to do with lift assist because those people weren't actually transported into a hospital scenario. Victoria, exactly the same. They actually had higher call-outs for falls, which was almost at 10%. So 1 in 10 people were calling an ambulance due to a fall, and 21% were actually not transported. So it was simply for lift assist. Pretty much the same figures here in WA. It's not going anywhere. Even though we're looking at data that's a little closer to the present, same sort of statistics that are happening. In the United Kingdom, over a decade ago, they were spending 150 million Australian dollars on ambulance call-outs simply to pick people up off the ground and put them in a chair. So this is an issue, and it's an issue that's not really going away. So that's why we're doing some of the work in this area and where you guys can really help because you're at the coalface. So we completed a systematic review, myself and my colleagues, and we looked at mixed methods. That just means a whole different set of methods to do with different articles that have been published. We found that 8 cohort studies had looked at getting up off the ground. Mean age was about 81 years. So I've done a lot of work with people who are receiving home care services, and they're usually about 83 years of age. So this is ever so slightly lower than that. I realise that age is just a number. It really is to do with our health, but when you're looking at a population level, it's around about 83 years of age that, on average, that people receive home care services. So for these 8 cohort studies, 44% could get themselves up, which is good. But that means 56% couldn't, which is not so good. So it's our job to try and help older people to be able to learn that technique if they can't actually get themselves up. So some of the factors that are associated with an increased risk of not being able to get up are mobility issues, so only being able to walk indoors, having a high tug score, so a tug is a timed up and go. You're sitting in a chair, stand up, walk 3 metres, turn around, come back to the chair. If you have a higher score to actually achieve that, you're at greater risk of not being able to get up. Inability to climb stairs greater than 20 centimetres. And I'll be showing a couple of videos as we go along. Being able to bring the hip through when you're on the ground is really important. And so with that 20 centimetres with a stair rather than being a little lower, same movement. needing to lift that leg to actually get it through. So that increases your chances of not being able to get up off the ground. Having some of these different health conditions, as you can see there. The interesting one is being overweight. And when I was doing a lot of my study around this, I actually contacted the fire brigade. And there's a proportion of Western Australians who are overweight and they fall, they're not injured and they can't get up. They call an ambulance, the ambulance officers can't get them up, so the fire brigade are called. So this is not only an ambulance officer issue now, it's also the fireys. And they're having at least 2 or 3 a month, and that was probably about 5 years ago. So that may have increased over that time. Having cognitive impairment, severe cognitive impairment, depression, increase in age. So the older we are, the less likely we are to be able to get up. And we know that frailty starts to come in as we get older, and also needing home care services. So we also had some cross-sectional studies that had looked at getting up off the ground. Cross-sectional study just means looking at one point in time. So not looking across longitudinally or a number of different scenarios where you're measuring or assessing something, it's just at one time. Average age for these studies was quite a bit younger, only 72 years of age, which to me is quite young these days. 13 of them were in the community, which is where I do pretty much all of my work. And the median time to get up was 6.7 seconds. So thinking, when we talk about getting up off the ground, we always start from supine. If you're unsure what supine is, it's just lying on the ground looking up at the sky, just like the puppy dog's doing. So that's the starting position, and then getting up. You start as soon as the movement starts, and then they need to be standing fully. And for this group, the medium number that could actually get up proportion was 66%. So they were certainly much fitter than the cohort study groups. 8 randomised control trials. So they had an intervention group and a control group. Normally with control groups, they're usually usual care or they're not active. It's like a sham program. We'll just get them to do some flexibility, something like that. Interestingly, in these studies, a lot of the control groups were actually active. So they might have been doing some strength training, but less intensively than the actual intervention groups. Intervention periods on average were 12 weeks, which as researchers, for some reason, we love to do 3-month studies. Maybe it's because a lot of services often go for 12 weeks. So then it can be comparable, but some went for 2 weeks, others went for 20 weeks. And there were mixed results. It's interesting that a couple had strength training plus supplements. A lot of the data around strength training and supplementation is to do with frailty. So they were obviously thinking that that may assist also with getting up off the ground. Only 2 of these 8 randomised control trials actually taught the skill of getting up off the ground. And for those 2 studies, one did get a significant difference between the intervention and control group for number of times they could rise and ease of rising. And for the other one, they had a significant improvement as well, and they were the intensively trained group. In the research, rather than what you guys are doing every day, there's usually 2 types of ways of getting up off the ground that are described within research papers. One is the conventional method, and I think Marianne might talk a little bit about that today, so I won't go into it too much. Generally, in research terms, you just get the person to get down on the ground and then you teach them how to get up in a particular way. One of the issues that we've found in our studies is that older people actually stress more about getting on the ground than they do about getting up. So the conventional method can be quite stressful for them because it's like, yeah, just get on the ground now. Okay. Whereas the backward chaining method actually teaches them how to get on the ground using certain techniques. And you can see there, stride standing, move to kneeling, and I'll have a video that I'll go through with that. And then the exact movements that they use to get down on the ground, they use to get back up. So research has found that participants find it way more effective and a lot less stressful. So you may find for your people that the backward chaining method may be a better way to go if they're stressed about getting on the ground. But I'll talk a little bit more, quite a bit more about different techniques anyway, about how you get on the ground. So this is Bex Townley. She is part of the Later Life Training UK team, and they do falls prevention training across the UK. She works with Dawn Skelton, who is probably one of the best falls prevention researchers in the world. And they actually teach getting up off the ground in all of their falls prevention programs. So I'm just going to talk you through how Bex gets up and down. Okay. Oh, that's cool. I don't need volume on that, so that's cool. You'll notice that she bum walks to the start of the chair. She actually stabilizes because of blood pressure. So in that movement up, she's doing stabilizing so that she doesn't get too dizzy. Then she's coming down onto the chair and she goes onto the box movement or all fours. So there's a lot of crawling, bum walking to get in the right positions, depending on whether the person likes to be on their knees or not. And then as you can see, she actually uses momentum of the body, whether it's knees and hips coming up, and she'll also straighten her legs out and she'll bend one of the knees and in order to get the hips around. So she's just about to do that now. She's also using the momentum of her shoulders in order to get side on. The leg goes out straight so that she can actually turn to supine. And see how she uses the legs for momentum. She'll straighten out that right leg in a minute. There it goes, in order to be able to roll to the side and rolling with the shoulder as well. Every time she changes position, she just waits a little time. That just allows you to adjust, make sure that that blood pressure is okay, which can be an issue for some older people. Getting up once again into that table position. Now she's going to crawl across to the chair, and this is when the hip is going to come up and through. Just there, that is the really difficult part for older people. That is the part that they usually find the toughest, is really dragging that through. So what I'm going to do is actually play this again, and I'm not going to talk so that you guys can just enjoy it. So that's the backward chaining method. Now, if you have someone who can't get up off the ground themselves, you wouldn't necessarily teach that all in one go. So you can teach that progressively over a number of sessions. And I'll show a couple of photos of different ways in which you can do that as well. So just a couple of things to remember with the systematic review. They did actually have pretty small sample sizes. When we're doing falls prevention projects, generally you're looking at 300 people and above. I think the largest study had about 200 people in it. So these were pretty small studies. And in particular, the RCTs were very small. I think the largest was 40 people. So these were not powered in order to find something out when it comes to falls. Control groups I did mention were active. And they were generally healthy older people as well, whereas you might be working with frailer older people. Some of the things to consider from our findings were teaching the skill of actually getting up off the ground is really important. And I'm not convinced that it's done that often. Resistance training alone does not necessarily help you with this task. You actually have to practice it as well. So we also did a biomechanics study where we put all the lovely markers all over 20 older people. We did ask them and made sure that they could independently get off the ground because we were really interested. It's all very well that researchers show that there's a conventional method and a backward chaining method, but what do older people actually do? Because we know as humans that we don't necessarily do what the research tells us the majority of time. So we had 20 older people, men and women, come in, 73 years of age. So apart from 2 people who had mobility issues, they didn't actually use an aid. These were pretty fit and healthy people. The average time to get up off the ground was just over 6 seconds. So we videoed them to see what technique they used. And interestingly, the majority of people went from lying supine to the sit-up position. So straight up, boop, and then they would roll one way or the other. They would get on all fours. I've got a couple of videos that show you how 2 people did it, but the majority actually go to that sit-up position. So as you can see, they're reasonably independent. They have a bit of core. Some did do the side sit and some did the rollover. We did not give them any technique or anything. We just said, get up off the ground, please. And they did that 3 times. So it was just however they wanted to do it. Here's one of the participants. As you can see, she actually used her legs as momentum into that sit-up position. And then she went to all fours, increased that base of support, and then stood up. So we'll have a look at that again, assuming as it only takes about 5 seconds. The momentum's really interesting, though, that's the way she chooses to do it, to get that body moving. And then to make that adjustment with the wider base of support when you're on all fours was quite interesting as well. And here's a gentleman from a slightly different angle. He's a little fitter, so he didn't actually need the momentum. Also, he did widen his base of support, but he didn't need it as much as the female participant did. Have a look again. So he's got pretty good core strength. He works out a lot, does a lot of swimming as well, straight up on all fours and straight up. So I must admit, I haven't seen that taught anywhere, but this is how these people get up off the ground. So for you guys, it's just remembering that there's not one size that fits all. And a lot of the older people that I've worked with have said, I've had knee reconstruction. My surgeon has said I'm never to lean on my knees ever again. So they use that one a lot. It's a little bit like I can't exercise because I'm asthmatic. They use that one a lot with me as well. And the third one is I'm too old to exercise. So we all know that all 3 of those aren't necessarily true. So it's just a matter of realising that there is not one size that fits all on this. We also, when we were doing the biomechanics study, we looked at their flexion for their hips, their knees, and also their ankle flexion. Interestingly, getting into that side sit in starting position rather than the sit-up actually had less degrees. It required less movement from them, pretty much, which was quite interesting. And I guess there's less momentum that's actually used in that side sit. There are not many studies out there that have actually looked at this from a biomechanics or a kinetics point of view. There was one in the UK that had a look at how older people get out of a bath. We don't really tend to use baths so much here in Australia, but interestingly, getting out of a bath is very similar to getting up off the ground. But older people actually use more hip flexion getting off the toilet, so probably because a lot of the time they're using that momentum, leaning forward to get off the toilet, rather than the amount of hip flexion they need to get up off the ground. But it's very limited research. One of the things that I did notice when we were doing this biomechanics study is it didn't seem to ring true as to why some people went to the left side to actually get up and some people went to the right side to get up. So after the first couple of people, I actually asked them which side of the bed they actually got out of. And there seemed to be a correlation between the side that they turned to actually get themselves up to the side that they were getting out of the bed. So if you're teaching someone how to get up off the ground, have a discussion with them as to which side they actually get out of the bed, because you'll probably find that that's a stronger side for them, and probably teaching them to go in that direction could be really helpful. We also did a short intervention study with people receiving home care services. And as you can see here, we use pillows, cushions, whatever is necessary to help the older person to be able to get up independently. One lady had helped her husband to get up off the ground because he actually had a lot of falls but wasn't injured for many, many years, and she would help him get up. Unfortunately, he died, and she was really concerned about what would happen to her. So from that day forward, she actually started practicing once a week getting up off the ground, because she knew that there wasn't anyone who was going to be there to help her. So she set about practicing that skill so that she knew that she'd be okay if the time came that she actually fell and wasn't injured. Many falls prevention programs look at strength and balance training of the lower body. But as you could see in those videos, the upper body is just as important for an older person getting up off the ground. So if you're doing and you're running falls prevention programs, can you please also add in some upper body strength as well? Because if the time comes where they do have a fall and they're not injured, they will be needing that upper body strength to get them up off the ground. I'm also running a falls prevention program for people living with mild cognitive impairment, and we've added upper body weights into that. And a gentleman was racing down the stairs to catch a train. He actually missed a step, grabbed hold of the rail and yanked himself around, steadied himself, and he slowed down and kept going down the stairs. And that afternoon he emailed me and he said, I think you might have saved my life being part of your falls prevention project. And because I was doing the weights on the upper body as well as doing the balance and strength stuff on my lower body, I was able to grab the rail and it stopped me. So he said, thanks heaps. It was great being involved. So please train the upper body as well. If an older person doesn't want to get down on the ground straight away and you're assisting them within their home, get them to practice on the bed. It's very similar. It's softer for them. They can practice the rolling. They can practice to all four, as this lady was doing. So that's often where we started them. It's also really important to explain why you're actually getting the people to do this. One of the participants in our project said, I'm often given exercises and told to do them, but not told why. And she said, this is the first physio that's told me why I should be doing this. And she said, I'm happy to do it now because I know the reason why, rather than you should just do what I tell you to do. So please explain it. I know you guys are like in a big hurry because you're all on the clock and you've got a million things that you have to do, but explain why you're doing it and you'll likely actually have the older person who wants to do it. Remember that getting down on the ground is very scary for them, so finding ways to get them down easily and building that confidence. And it could just be, as you can see there from the fourth picture, could just be on the very first time getting them down to kneeling and then standing back up again, down to kneeling, standing back up again. And that's as far as you go for the first session, and break it down into chunks for them. Some practical exercises that you can do to help them. Bum walking. Doesn't need to necessarily be on the floor, can be on the bed as well, can be on an area that's higher if you've got that within your gymnasium. Bum walking on the floor, chair or bed is a really great way to strengthen both glutes and also help with core, help with hips as well. And if they need to be able to get to some furniture and they can't crawl, bum walking is a good way to do it. Wall presses, which are just push-ups against the wall, really important for upper body as well. Having that trunk mobility is important. Side bends, back extensions. So you guys know all these things, but it's just remembering to actually train them as well. So balance and strength of the lower body, really important. But if they fall, they need to be able to do all these things as well. So as to be able to get up. Lunges are really great too. So I sit to stands. I often try and get a lot of our participants. Most people watch some sort of television at least once a day. When the commercials are on, just do sit-stands during the commercials. It's the only time you need to do it during the day. Often they'll be watching the news, so I suggest that they do it during the news. Injury Matters have some wonderful resources, which I'm sure are probably in your packs. So they've got them for using your knees, using your arms. As you can tell, though, by my study, there are a myriad of different ways that you can get up off the ground. Once they figure out the way that's best for them, it's them practicing it. And what you'll find is as they get stronger and better at it, it'll become less awkward. And as one of my participants said, I can get up, but it's ugly. So maybe it'll get a little less ugly over time. They also have First Nations resources as well. If you're working with Aboriginal people, then fantastic to use these as well. Dawn Skelton and Bex Townley from Later Life Training, you saw Bex get down on the ground in the backward training method. They're the only falls prevention program that I know that is research-based, it's shown to prevent falls, and they actually teach the skill of getting up and down off the ground. I haven't actually seen any programs here in Australia, so I'm really hoping to learn something from you guys tonight. That program's 6 months in length and it's face-to-face. And Dawn and Bex are doing some great stuff in the UK on that. So there's a couple of questions I would like to ask you. Before I do that, I just have one shameless plug. I actually write a monthly healthy aging blog. It's for older people or health practitioners who are working with older people. It's simply to give some ideas and evidence-based research on helping older people to live independently for as long as they choose. So it comes out once a month. If you'd like to subscribe, you just go to the bottom of my website and put in a first name, doesn't even have to be your own, and an email address, and then just once a month it'll come to your inbox. And I do have the references at the back if anyone needs them, and if you can't get them online, then feel free to email me and I will send you whatever reference you need.
Thank you so much for your presentation, Alyssa. We're always very grateful to have your knowledge and skills brought to our workshops and events. I'd now like to introduce Marianne Fabling. So Marianne is an Art Pro registered physiotherapist working as an injury prevention specialist and rehabilitation program physiotherapist. Since early 2022, she's been a key part of our team at Injury Matters, delivering allied health falls prevention education and workshops, building the capacity of the WA falls prevention sector. Marianne brings a wealth of experience from her previous leadership roles where she developed and led falls prevention programs for older adults across public, private and non-profit sectors. She also holds a postgrad qualification in business management and occupational health. Yes. Thank you, Marianne. Okay. Hi, everybody. Can you hear me all okay? Okay, I'd also like to pay my respects to the Whadjuck Noongar people as the traditional custodians of the land on which we are meeting today. We'll speak up. Okay, so Suzanne asked me to present on getting up off the floor safely. And when she first asked me, I thought, oh, this is not something I do very well. I think, though, it's something that we all need to attend to better, and we all need to start thinking about how we interact with older adults and how our interventions are better at helping people get up off the floor. I'm going to talk today about some of the evidence-based screening, assessments and exercise interventions. So we're going to refer to the CDC compendium, which is out of the US, out of the World Falls Guidelines, which has already been referred to, and some of you may have already read through the guidelines. As Suzanne said, it's well worth reading through them. They're quite lengthy. There are summaries, and every time I read through it, I get something else out of it.
It's very comprehensive. And also just a bit of a summary through the Cochrane report. So the British Medical Journal article in 2008 said that there was an inability of people to get up off the floor was very common. So they found that actually 2/3, which is similar to what Alyssa has already said, of all over 65-year-olds were unable to rise unassisted, and that 1 in 8 people who fall will lie there for a long time. And as we know, if someone is left lying for a long time, this leads to other complications. But also what lying for a long time means that the next time, that when they're back up on their feet again, they're more likely to fall because they've had that long lie. So it's really important that we do teach people and we have people more confident in getting themselves up off the floor. This study, interestingly, also found that although alarms and other assistive devices that people might wear or have in their house, although they might have them, that they don't use them. So that might mean that they're not actually wearing them when they have the fall, or that they often will have the device on them, but they don't know or don't want to use it because they're scared of using it. So I think that it's very important, particularly for those people who are living at home alone, that they have some sort of a device that's triggered and monitored, so that if they do fall, whether or not they lose consciousness, that there is help at hand and they're not left lying for a long time, because chances are most of them won't be able to get themselves off the floor if they're uninjured, or if they're injured, it'll be even more difficult for them to get off the floor. One of the people that I was assessing last week, she fell at about 4 o'clock in the morning. She fractured her hip. She lives with her daughter and her daughter's family. She got herself up off the floor and put herself back to bed with her fractured hip because she didn't want to wake anyone in the house because she had a fractured hip. She's actually doing okay, but that's the sort of thinking that some of these older people who fall have. The stats are even higher in those that are over 90. So this particular study found that over 80% of those in the 90-year age group were unable to rise off the floor unassisted. Unlike my dad, who I was at the park with on the weekend, and he sat down on the grass next to me and stood up again. So I was quite pleased to see that he could still do that. He also wears his assistive device at home that's monitored. Okay, as we've mentioned already with Alyssa's talk, there are many, many different ways of getting up off the floor. There's what I'm calling the traditional method, which is the way I was taught when I was at university 100 years ago, to get up through side lying into 4-point kneeling and then standing up through half kneeling, using a chair or not using a chair. Then there's a backwards crawl using furniture. Then there's turning to stand with or without a chair, which I'll show you a little bit more later, which is actually a easier way to do it, but it's not what we do. It's not how we teach people to do it. There's the people who are physically able, who get up straight off the floor, and there's even those who can get up cross-legged from the sitting position, so through like a yoga lotus position or a cross-legged position, and they can just stand straight up if they've got very, very good hip and knee range of movement. And then we've already mentioned the backward chaining method, which is a really great way of teaching people who aren't able to or don't have the confidence to get up and down off the floor to get up and down off the floor. So looking at the evidence, there's many different compendiums or groups of information that you can get really great information from. So what I decided to do this time was go through the different guidelines and see whether they mentioned getting up off the floor or whether the particular studies integrated getting up off the floor as part of the research. And this is what I was able to find. So in the WHO guidelines for physical activity, we know that, I'm not going to go through what they all are, but basically they do recommend that people are doing strengthening exercises throughout the week and that they're also doing specific balance training exercises once they're in that over 65 age group. So as a summary from the 2019 Cochrane review, we know that exercise interventions generally reduce the rate of falls compared to the controlled when there's a randomised controlled trial. We know that the inclusion of strength and balance in these exercise programs reduces the rate of fall by 34% on average. And we know that Tai Chi and other similar type dance exercises reduce the rate of falls by 19%. We know that walking programs on their own do not have any evidence-based research to support that they are helping with falls prevention. So when someone is just doing walking for exercise, we need to make sure that they're also incorporating some balance specific type exercises in there. And we don't know about yoga, but at the moment there is nothing to support yoga, but there is a large worldwide study that is underway and should be released soon. And next year, has it been released?
Australian music.
The Canada one. Yeah. I haven't published it yet. So we're just waiting on that. I can't imagine that it wouldn't, but I guess it depends on where the baseline is. So the CDC, or the Centre for Disease Control and Prevention Compendium, this particular version was released in 2022. So the purpose of this compendium is to showcase the different falls-based, evidence-based interventions. It's based in the US, based from the US. So this is the 4th edition, and it has 34 single interventions, 17 of which are exercise interventions and 17 are clinical interventions. And then there's also 16 multifaceted interventions, which look at multifactorial, address multifactorial risk factors. So each published study gives the link to the study, and it also gives a lot of information about each of the studies. So it gives an overview, it describes the population, the location, what profession or what training the people delivering the program have, and it gives key elements of what the study involved. It's actually a very good way to get a lot of information in a very short space of time, and it's really available. You can just Google CDC Compendium 2022 and you can download it and read it. So I went through each of the overviews to see how many of them actually included getting up off the floor, and there were 3. So there was the study by Nijmegen and Smulders, from Nijmegen, and it was Smulders et al., which was set in the Netherlands, and an OT and a physiotherapy taught getting up off the floor and how to get up off the floor safely. And of the 11 sessions of this particular falls intervention program, it was a group program, one of the sessions were devoted to this. And then there was the Falls Team Prevention Program, which was in Nottinghamshire in the UK in 2010. This one was in an individual's home. And as part of this, an OT visited the home. And as part of the hazard assessment, they taught the person in the one session to get down and up off the floor. So at least it was included. Then we've got one from Australia, which is the FAME Falls Management and Intervention program by Skelton in 2005. And in this one, it was again in the person's home, and the OT taught techniques to get up off the floor when conducting the home hazard assessment. So again, it was similar to the other one, but at least they included it. They were the only ones I could find out of all of those studies that are included in the CDC compendium. So the World Falls Guidelines, which we've mentioned already, came out also in 2022. It was a panel of 96 experts from 39 countries around the world, and there were various working groups and various steering committees. They base everything in the recommendation is based either on evidence, and they base it on strong evidence or less strong evidence. And then when there is not evidence, they give it as an expert opinion or an expert, what's the word? Expert advice, I guess, to include where there's no evidence to support. So just as a summary, the World Falls Guidelines recommend a multifactorial assessment. They stratify the risk of an individual into 3 different categories, and they really ask you to manage the risk factors. Of the various screening tests, walking speed is the one that has the strongest evidence, and they recommend referral to a physiotherapist for targeted programs for those people who are most at risk of falling or are the frailest. So just a little bit on the falls risk stratification. So there's those people who are in the older age group, but they haven't had a fall, and they recommend that you take advantage of any intervention that you have with them to give them advice on falls, making sure that they're doing some falls prevention and balance training activities, whether that's bushwalking, so they're not just walking on flat surface, or whether they're doing some actual targeted balance exercises. The second group are those that might have had a fall or might be at risk of falling but have not had an injurious fall, or are not at risk of a serious fall, but they need some exercises, they need some strength and some balance training. And then the third group are that frail group who are very at risk of falls, and I would think that these would be the people who wouldn't be able to get themselves up off the floor, although that's not specifically mentioned. So just a few of the screening tools that are recommended for use in the World Falls Guidelines, and there are many of them. As I said before, the timed walk or the gait speed test is the one with the strongest evidence. And they do actually mention the floor transfer test, which I'll go into a little bit because it's getting up off the floor. So the World Falls Guidelines I went through and tried to see where they'd referenced getting up off the floor. And the quote is, "It may be useful to assess rising from the floor." So the floor transfer test is a valid and reliable measure for screening for physical disability, frailty and functional mobility, for assessing the likelihood of injurious falls in the next 12 months. I've got more on that on the next slide. So regaining the skill to rise from the floor is most successfully learnt through practice of each of the specific movements required, which we've talked about in the previous presentation. They also specifically mention backward chaining, and some falls prevention programs also specifically focus on this and have shown to have success in regaining this function, and they give the example of the FAME program, or the Falls Management and Exercise Program, 2005. So the floor transfer test was described by Berglund and Lark in 2005, and it's a predictor of the likelihood of injurious falls in the subsequent 12 months if the person is not able to independently rise from the floor. Oops. Okay, so it's a test that assesses the functional ability of older adults to sit down on and then rise from the floor, and it's in order to assess the risk of falling. It measures the time necessary to sit and then from standing, and then to return to standing. During the floor transfer test, an individual is instructed to transfer from the standing position to the sitting position on the floor, and then return to the standing position in the way he or she prefers. And they may or may not use a chair for support. The average time to complete in seconds is 20.9 seconds, and that was in people who were post, so a few years down the track from having a stroke. That was who the study had been done on. So it wasn't done on people who hadn't had any neurological incident. So rising from the floor, this is also from the World Falls Guidelines, and this is my lovely AI-generated picture of somebody getting up off the floor. I first put in older adult getting up off the floor using the seat of a chair, and I got all sorts of things. I got people standing on the seat of the chair, I got the chair underneath them, so I had to be very specific in what I wanted the person to do, and finally I got that, so I was very happy with that one. So rising from the floor is most successfully retrained by practice of each of the specific components. So with that and what we've already talked about, Alyssa went through the backward chaining and going from standing and going through to down on the floor and then back up again. As you've mentioned already, most of us, if we're working in the community or if we're working in a hospital setting or if you're working even individually in the person's home, you're really worried about that person. If you get them down on the floor, how are you going to get them back up again if they actually can't do it themselves? So one of the ways, and I'm calling it a sandwich, is to practice the getting down, but then to practice the getting up on the person's bed. And obviously that's what we would all do. And I would advise them to practice the components on the bed, but to have somebody standing by because you don't want them going off the bed. You really need to get them to regain their confidence because the fear or panic of not being able to do it is real, and it is stopping people from even practicing it. And then it's even worse if they get into the situation where they've had a fall and they just don't know what they're going to do. And it's very important also to look at the person's native technique to see what is the easiest way for them to do it, how their body organises themselves into the movement, so that then you can work on that and strengthen that. I'm not going to go through this because this is a different version of backward chaining. But again, it's just breaking it down into the various components. There was a study done in 2002 by Hoffermeyer, and it was from Michigan. And they looked and they called it the native floor rise strategy. So that's what they called the way that the person chose to get themselves off the floor. And they did a short-term strategy-based intervention, looking at the way that person went to get themselves off the floor and then to break down the component parts and work on that. They did it over a 6-week, not 12, a 6-week study, and they found that it did improve the person's confidence in getting up off the floor. So they were looking at the person's confidence in getting up off the floor in those that already could. Talked about the resource. I must admit that this is the extent of my normal getting up off the floor training, is giving out the resource and perhaps briefly talking through it. However, in the sorts of work that I do and have done over the last several years, I get to see people who do this very well. So I asked 2 of my colleagues, 2 physiotherapists who work in the community, so they work for community physiotherapy, to record themselves in how they teach people to get up off the floor, because I've seen them do it and they do it really well. So I've got a few short recordings now to show you of people who this is the way they show their clients, their patients, how to get up off the floor. And we're just going to have to do a little bit of adjustment to the tech so that the noise works.
Take your bearings. time you do go into a bit of short hearts racing, the main thing to do is just try and get control of your breath. Just make sure that you haven't got any major injuries. By that, can you actually? I tend to get my patients ankles. Just make sure that nothing's broken. They can pat down as well using the front and the back of your hands. See if any. You might want to just make sure that your knees and just bending your knees up and down, letting them rotate in and out. If anything is broken, have access to the ambulance. So you need those bracelets, necklaces, stay away, carry the mobile. And I highly recommend that if anyone has any shoulder problems, so just making sure that everything's okay, get your bearings, and then try and get up. So there's two things. These are good in that they're not both replaced and any weight through them. What I suggest is that you roll over onto your hand. So by that, if you're all the way down, then what you do is you bend your knees up and you roll over along those sides. Then you push yourself up so that your hands are so forward. So on your hands and your knees. And then you have to find something that's low enough to get. So dining room chairs are really good, or ottomans. So just crawling over to your nearest dining chair, and once you're there, have a breather. So it's going to be your arms really that are going to help you off. So I tend to put my elbows and my whole forearms on the chair. I use my good leg, so whichever is your strongest leg to go up first. So I bring my right leg, if my right leg's my strongest, and I tuck my toes under on the opposite side. Try to get some fulcrum with my toes so that they can push up. Then I put all my weight through my elbow, and I pretend someone's actually lifting me up by my belt at the back. So lift your bottom right up, and then you can make little steps forward, get there, and then you push with your hands and your. So just take your time and don't rush. And then also just keep in mind your good leg's the one that goes forward. Try and tuck your toes. The second video, I'm going to show you how to get up a bottom walking if your knees aren't in. Thanks.
I love the way that Dominique describes that, and that is how she does it in her classes. So in community physiotherapy, for those of you who don't know, you have a number of people in the group in a community centre. So you're a physio on your own in the centre, delivering falls and balance classes that also have upper limb exercises. But we don't always give as good an explanation and demonstration as Dominique does. So the next one is her showing people how to go up backwards using the furniture.
So what the main thing is, again, is to make sure that you don't have any injuries. Knees, check your feet, check your hands as well. We didn't go through that before. Please ensure that your wrists aren't broken. Just keep your arms a little bit supple and make sure that they're not injured as well. If you have time, and main thing is not to rush, and you know that you don't have any injuries, then just once again breathe. Make sure that you've got someone around you who settle things. Take your time. You're on the floor. It's not going anywhere. Just you're as low as you possibly can. You've got the time to be able to get up. So just get your strength back and get rid of the panic. Now, with your knees, what I'll suggest you do is to bottom walk. So this is where you do also your arms as well a little bit. And backwards is always easier than bottom. So you actually do need to use your tummy muscles to be able to do this. And you lift your bottom and you wiggle your bottom back. Really use your legs that much. And I've taught people who have had a dense hemisphere how to do one leg. They one arm, and they are able to shuffle their bottom right back to the sofa. Once you get to a low piece of furniture, like your sofa is one of the lowest that you can get your bottom up, you get rid of that top cushion. So the main thing is that top cushion, something that would be able to help you get back up. So put the cushion there if you want to, or you can move that all out of the way. Now, if I can get you to come around and have a look just how low your sofa is, it's really a small little step to be able to get back up. And once you're on that sofa, there's a big psychological gain. So once you're there, this is where you need your arms once again. But you try and use your feet and bend your knees, lean forward as much as you can, and you try and push down. So you can either use your hands or you use your hands there. If it's too much, then you actually get a pillow. So you wriggle over and you get cushions or pillows or whatever you need to be able to get the bottom up. So that one there is a little bit spongy than this one here, but you try and get a bit of fulcrum, a little bit of leverage to be able to get up onto that low cushion. Once you're there, you really just have to slow and keep them low. Push your bottom back. Once you're on that sofa, you know that you're halfway there. Have a breather once again. It's all about getting your bottom raised up as well. So then you want to be able to. Once you're there, it's actually quite easy. So just push your hands, try and bend your knees as much as you can, and you just get your bottom up that level there. So once you're there, you know that you get up. The main thing is not to panic. Be able to take your time to be able to get there. But if you have any major injury, you do need to call an ambulance, and you also, what is my action plan? The ambulance to be able to access your house. So they need entry in the house. They don't have a key, or if neighbours don't have it, or don't have that little lock box out the front there for the ambulance, then it makes it awfully difficult to be able to help you. Don't have that come in. So do allow them to have access, and try and think about that now before it's actually. I hope that's helped, those two different ways. Once again, we do strength exercises for both arms as well as legs to prevent not being able. Thank you very much.
Okay, so Domini's one of the physios who, as I said, works for community physiotherapy services. One of the things she mentioned there that I haven't mentioned a lot yet is the importance of people having an alarm, particularly if they are at home on their own, living at home, or if they're even at home living with someone else, like I mentioned the lady previously, that they have an alarm and that it's a monitored alarm. I think that's really, really important, and that part of that monitoring system is that they do have the way to access the house for the ambulance or for other help to get in. So the next number of slides are from another physio called Bronwyn Fuster. Bronwyn is also a Feldenkrais practitioner. For those of you who don't know what Feldenkrais is, in my non-Feldenkrais practitioner way of explaining it, they really work on movement patterns and the way the body wants to move, rather than like we tend to do as health professionals. We tend to teach and do things in like the sagittal and the coronal plane. So that traditional method of getting up, where we roll onto our side, we push ourselves up, even when we're teaching people to do hip abduction or hip extension, we teach them to do hip abduction, hip extension in straight movements instead of like the muscle is designed to do it with rotation, to do it in the way that the muscle is designed to work. So with Feldenkrais and with the way that Bronwyn teaches getting up off the floor, she very much uses different methods of getting up, of breaking down the various movements required to get up off the floor. The information that she gave me to start with was a video of 14 minutes long, and I didn't think that we would be able to watch it all. However, it's really, really interesting to watch. So I've taken small parts of what she gave me, and I'm just presenting that now. And it's different ways to think about the individual components of getting up off the floor. So I'm just going to quickly explain it so we don't have to keep going in and out because there's 4 different snippets. The first one is rolling into a ball. So instead of, we tend to teach people to roll, you know, arm out, roll across. The way she teaches it and the way the Feldenkrais person would teach it is to roll to the side, but to roll into a ball. So she will show you that. And then to get up into side sitting. From there, she teaches people to practice rotation in side sitting, and she also gets people to practice the side sitting in the chair as part of the group, which is the same sort of movement as you would do on the bed. Again, she gets people to practice these movements at home in the bed that she demonstrates to them in the class. So again, it's like that sandwich, so going from both ends. Then she'll show a different way of getting up into 4-point kneeling, and perhaps I'll talk about the other one when we get to it.
It's rolling into the little ball, then allows us to come up to sitting quite easily. Because if I've rolled into a little ball, and I come to here, my head's going to be just hanging there. I can look towards the ground, and to sit up, all I'm going to need to do is to bring this leg like this, and as my leg moves away from me, I just bring my head with it. That will bring me up to sitting. Okay, so that's also something that's useful to practice. What people often do is when they go onto their side to come up, instead of letting their head come forwards and then follow their leg, what they do is they think, oh, I've just got to lift my head up to come up onto the side. And that's actually quite, you could hear it in my voice, it's actually quite hard to do that. So they're just 2 things that are quite useful to do. Now, in terms of getting off the it's rolling into the little ball, then allows us to come up to sitting. So could you keep your right hand there, bring your left hand over, and your legs across. Look over behind your right shoulder. Then come back to the middle and then go the other side. Have a look here.
I love the way in both of their videos, they've both got the dog featured.
So could you keep your right hand?
Next one.
Because that, once you can get on your side like this, that's what allows you then to put your hands and knees. Is what you're going to need to be able to get off the floor in any of the different ways that we go that we'll be.
Okay, in the final snippet of the whole 14 minutes, she talks about something that Alyssa also mentioned, which was that most of these people, because of their age group, you know, they do have reduced balance, and so they do have reduced, they need to have a wide base of support. So she does mention that, and she also, in the technique that she uses, is she's taking that into account, but also thinking about having more than two points on the ground. So she's having 3 or 4 points on the ground at all times, which I think is really important as well. One.
Like this, that's what allows you then to come onto your hands and knees.
Oh no.
Going to turn and face you. Okay? So to go down, I'm going to turn back this way. What this avails is that you always got 2 feet on the ground. And when you stand up, you've got quite a wide base of support, so it's much more easy to balance here. Okay, now, if I wasn't quite as strong as what I am, then I could always put one hand on the ground down here to help me, so that when I come up, I've actually got 3 points of support. Okay, to do this. Okay, or if I wasn't quite that strong, I could, and my balance was not, that as good again, I could actually put both hands on the ground on this side. Obviously, I can't do it on this side, so there's only one side that you could possibly put your hands down, and then you've got to put your hands down and swivel again to turn, and now I've got 4 points of control, so I can take time getting up. Why I also like this method is because if you have a chair or you have something that you can rest on, instead of having to put your hands down low here, and a lot of people can't do that because they don't have the flexibility in their hips, then if you can get yourself a chair, instead of putting my hands on the ground now, I've got something higher to do that, so I don't have to. I don't have to go all the way down. So now I've got this here, and I can push up onto the chair. Then I've got something.
With the method where she was using the floor, you need a lot of hip flexion for that one. But then adding the chair in, you need less. And I think it's really interesting having that chair in a different position so that you're moving in a rotation movement rather than requiring to come straight up. So it's another thing that you can do, and another tool in your toolbox, if you like, that you can help people with. Move now. In the day of tech difficulty today. Okay. Another thing that's very interesting, and that again Alyssa mentioned as well, is compliance. And if you give people a reason for doing something, you'll often have more buy-in into doing the exercise at home. A study done in 2012 out of the US found that only 21% of people who were retired in the US, I can't remember which state it was in, only 21% of people were doing a structured exercise program. A study that's come out this year, so 2024, and it's on behavioural economics, and it was in the Australian Journal of Physiotherapy, talks about adherence to structured home exercise programs being as low as 30%. They look at the contributing factors being their attitude to the exercise, their motivation to do it, and their level of self-efficacy. So they looked at 10 studies, and this included 3,899 participants, and it showed that the adherence to structured exercise was as low as 54%. So giving people a positive reason. So obviously, positive reason to be able to get off the floor is that you can get off the floor. So it sort of speaks for itself. With Also, one of the things that is quite different to the way we traditionally teach people to do home exercise programs is that they recommend to give people 3 or fewer exercises at a time. So that's really something to think about, and trying to get that habit streak. So just looking at the traditional exercise programs that we tend to use when we're basing our falls prevention programs, generally, we would use the Otago program. This doesn't include upper limb exercise, and it doesn't include getting up off the floor. So we need to, when we're implementing these exercise programs based on the Otago program, we need to add those in. The LIFE program is the same. So a number of programs are based on the LIFE program. So again, it's thinking about when you're implementing these programs, these evidence-based programs, that you add extra things in. So you think about adding in teaching people and assisting people to get up off the floor, and also some upper limb strengthening to help them get up as well. So just some recommendations is have a high challenge, making sure that people are challenging their balance, whether that be from an actual exercise program of strengthening and balancing exercises, or whether it's just in their everyday life. For example, if they're going for a walk, that when they're walking, that they perhaps walk in and out of the fence at the park or something like that, so that they're challenging their balance and not just walking in a straight line. Making sure that people are being physically active and that they're achieving the guidelines set by the World Health Organisations, that they do ongoing exercises and that they integrate exercises into their daily life. That's really important. And I've added in here now, include education and specific exercises to help people getting up off the floor and to make sure that they're confident in getting up off the floor. Incorporate walking training, balance training and strength training into your programs, and just remembering that some specific populations require specific particular assessment and exercise. Does anybody have any questions or anything they would like to add?
Thanks, Marianne, and shameless plug as well. Marianne delivers our on-demand training for allied health professionals and other health professionals in the falls prevention space. So you can see the list of those workshops that we offer and she delivers for us. So those include Active Balance, which is a program based on the Otago exercise program. We also have the exercise with Otago, well, using the Otago exercise program specifically for allied health professionals, and we also have the LIFE training as well. So all of the information for those are available online on our website, and yeah, I encourage you to have a look. And I know Alyssa said before that she was delivering a shameless plug about her blog and website, but I do also really encourage you to have a look at that. It's a fabulous resource, I think, for all of us. And she has some really interesting, very practical, real world information on there as well. So our next speaker is Associate Professor Christy Harper. So thanks, Christy. She's an occupational therapist and clinical researcher. She works across Curtin University and Sir Charles Gardner Osborne Park Healthcare Group. Christy specialises in falls prevention and management in acute hospital settings. She leads a team of clinical researchers working on a program of research largely focused on frailty syndromes in older adults, including falls. She is on the executive committee of the Australian and New Zealand Falls Prevention Society, and we are very, very happy to have a West Australian representative on that. And she's also part of the West Australian Older Adults Health Network Falls Management Special Interest Group. So Christy's here today to talk to us about fear of falling.
Okay, thank you for having me here today. Okay, so what is fear of falling? Fear of falling is defined as a lasting concern that leads an individual to avoiding activities that they remain capable of performing. So it's recognised as a significant psychological consequence of falls. The World Falls Guidelines recommend that clinicians use the term concern about falling when engaging with older adults. They state that while fear of falling is a term used in much of the available peer-reviewed literature, making inquiries about concerns offers advantages to fear of falling because I guess it's seen as less intense or emotional and maybe in a language that's easy to understand if someone's saying, are you concerned about this, rather than you're fearful of falling. So in this presentation, I will use both fear of falling or concern of falling. But when you're speaking to older adults, I encourage you to use concern of falling. So why is it an issue? Fear of falling essentially is associated with more falls. So around 60 to 80% of will fall again. Some of the tools where, like we talk about the falls efficacy scales, if people are around rated as severe in some of those tools, they've said some of the rates around 60 to 80% might fall again. So you're dealing with a high-risk population that is likely to have a fall. So it's one of those risk factors that we need to address. Coming from a hospital setting, I know that fear of falling is something that you see, but often we're not that great at using the tools to identify it. It's rarely handed over to community services to continue to deal with in the community. That's probably why it's a good reason we're talking about today, and it's something that we continue to raise. So fear, sometimes fear can be a helpful thing. So in the literature, you might see them talk about adaptive and maladaptive behaviours. So adaptive behaviours associated with concerns of falling are those that reflect a realistic appraisal of one's falls risks, and so therefore can be labelled as protective. So adaptive or helpful behaviours could be potentially reduced risk taking. So if we're at we have poor mobility and we know that and we're not that great on our feet, we might ask someone to change that light bulb for us and not climb the ladder. So those responses are appropriate. But in contrast, fear can be unhelpful or lead to maladaptive behaviours. And this is where there's a mismatch between concerns experienced and one's risk of falls. So when someone overestimates their risk of falling and underestimates their ability, this can lead to fear that may be irrational or excessive, which impacts on their function, activity, attention, behaviour. It can lead to thinking the worst, resulting in that activity restriction and social isolation. And the presence of high concern of falling, whether it's adaptive or maladaptive, should be considered a red flag and highlight the needs for our further assessment. Another term that you might see is falls self-efficacy. So fear of falling and falls efficacy, you might see balance confidence or gait confidence. So it's just another term that you might see. I guess some of the tools that were used to assess fear of falling in terms of the falls efficacy scales were originally developed on Bandura's self-efficacy theory. There is some recent literature that's argued that fear of falling doesn't necessarily simply imply sort of low fall self-efficacy, but it maybe acts as a mediator between fear of falling and falls. So fear of falling is a significant issue for older adults. It has been found that after falling, around 48% report a fear of falling and around 25% actually report curtailing their activities, so they're moving less. So we know that people that haven't had a fall can also experience fear of falling. So it's not just necessarily in people that have had falls. They might have seen people fall. They might have understand the consequences from that as well. There's one study that I saw, I think they looked at 153 studies. It was a global study. So it looked at a global prevalence of fear of falling around 49%, ranging up to 90%. There's some stats around community versus hospital, so still around that 50% mark there. But essentially every second person you see could have fear of falling. So it is quite high when you look at it like that. So why do we need to invest in fear of falling? No one wants to live in fear, essentially. We all want to engage in activity and to not become isolated, to have as much quality of life as we can. We know it's also about preventing falls and the injuries from falls. And if we can do that, it's also associated with lower healthcare service use and lower costs. So it's useful to reflect on what happens to us when we experience fear. So obviously we have that fight, flight or flight response is activated with the release of the stress hormones. But you can see there some of the physiological changes that you could observe when someone's experiencing fear in terms of the cardiovascular changes, so increased heart rates, blood pressure changes, respiratory adjustments in terms of rapid breathing. You've got the muscular response in terms of muscle rigidity, shaking, trembling, which impacts on our balance and coordination. Metabolic changes, so there's increased glucose release to help us do the fight or flight. The skin responses in terms of sweating or goosebumps or cold extremities as blood is redistributed. And the cognitive effects, so concentration can be impaired, it can be less flexible with thought, and reduced executive functions. So you can see some of these changes not only make someone at high risk of having a fall, but it's, as associated with the, restriction of activity that leads to functional decline as well. So what are the contributing factors of fear of falling? So previous falls is a big factor. It's often cited as the most critical factor leading to fear of falling. Obviously, experiencing a fall is a traumatic event which can lead to anxiety about future falls, regardless of whether injury has occurred. You've got gait and balance impairments. So gait and balance are central risk factors for falls and are strongly associated with development of fear of falling. Sarcopenia and frailties, you've got that loss of muscle mass, strength, and it's strongly correlated with falls and fear of falling. We've got the low self-efficacy, so low confidence in your own ability to avoid a fall while engaging in everyday activities. Depression and anxiety. So depression is a major, and anxiety are major psychological contributors to fear of falling. Older adults with depression are more likely to develop a fear of falling and avoid activities leading to further physical and psychological decline. You've got activity avoidance and physical inactivity. So we know that fear of falling leads to that avoiding activity essentially, which leads to that vicious cycle of patients not moving, which places them at high risk of having a fall. And you probably have all seen that cycle, which I'll put on the screen in a minute. The other thing is chronic pain. So people that have got joint pain in their back or anything that limits their mobility can increase their anxiety about performing everyday tasks. And there's some other factors to consider. As we know, falls are very multifactorial in terms of, do they experience cognitive decline? If they've got a vision impairment, what's their environment like? And the effects of medications, if it's, making them dizzier and things like that, then they possibly are fearful that that can lead to a fall as well. This is a bit of a busy slide, at least it's come out okay. But it's come from a newer study that's mapped the existing literature on fear of falling. I think it's helpful to show the range of factors that can impact on fear of falling and how complex it can be. The study reported that most studies have focused on the physical health related factors, particularly regarding balance, gait, with less attention paid to the cognitive, psychological, social and environmental factors. Moreover, more research could be done on the demographic factors beyond age and gender, with an interdisciplinary collaboration more with the social sciences as well. So what do we see in our patients or clients and how do we identify fear of falling? So you might see the behavioural signs. So patients or clients that have previously avoiding or, they've avoiding previously enjoyed activities. So, and you have to dig sometimes for that. So patients will say, no, I use my scooter, I go to the shops. And then you actually say, well, when's the last time you did that? And it was 2 months ago. So then you'll start to see that they actually are starting to restrict their activity, and even though they might say that they're still doing these things, it hasn't been for a long time. You've got the emotional signs, so anxiety when walking around, that hyper awareness of surroundings, perceived inability to walk, so they might tell you that they're not that great on their feet, and low mood. And then you've got your physical signs, so the tense posture, reduced stride lengths or an unwillingness to walk unaided. Sometimes they, want to use a frame and they might not actually need one yet. These are some more motor signs that you might see in terms of that retropulsion, the postural instability and the postural compensation, knees that are and hips that are flexed. We talked about the changes to gait. They can look, those protective patterns, so walking with their hands out or lunging for the furniture because they're worried they're going to fall, which makes sense. These came from a qualitative review which looked at where patients had directly shared their experiences of fear of falling, but the findings revealed that fear of falling in older adults manifests as 4 distinct aspects, from apprehension arising from unpredictability of falls, unease related to the personal vulnerability, heightened vigilance concerning the environment, and concern about the potential harm for falls events. And it highlighted that the extent to which individuals experience each aspect may differ, and so consequently interventions need to be personalised. They need to assist in reducing that apprehension, enhancing perceived control, promoting physical strength through exercise, addressing that emotional vulnerability, improving environmental safety, and especially knowledge about falls and fear of falling. This is that vicious cycle that you've probably seen before, but it just really highlights that's a cycle where someone has that fear, they move less, and they're higher risk of having a fall. So I think they were saying, 20 to 55% experience restrictions in their daily activities. So getting a clear understanding of how people are spending their time is quite important. So when to screen, you need to look at fear of falling possibly after a patient's had a fall, during routine assessments and our multifactorial falls risk assessments, when there's a change of mobility and function, probably post-hospitalisation or there's been a major health event, and when older adults are showing reduced signs of confidence. So there's lots of stages that we might be able to look at fear of falling. And it's about really addressing it early so that we can make a difference in terms of, helping them avoid that sedentary behaviour. So these are the World Fall Guidelines recommendations. So you can see they recommend evaluation of concern of falling, use of a standardised instrument in terms of falls efficacy scale, international, that these are also used in acute care and long-term care facilities. And in terms of intervention, they recommend exercise, CBT, or occupational therapy to reduce fear of falling in community dwelling adults. And I'm sure we've talked about the draft Australian falls guidelines that are hopefully coming soon. So in terms of community care, we've got, again, engaging with older adults to identify and manage, addressing those concerns about falling, for older people with fear of falling, facilitating access to prescribed exercise, CBT or OT, and looking at any potential barriers and liaising with older people and their networks, so carers, friends, people that also provide support for them. These are the guidelines for the hospitals, so essentially reviewing all falls and looking at patient factors, including fear of falling, and again, exploring those potential barriers to helping patients move or take action. And for residential aged care, so again, reviewing every fall, seeing what we can do to manage that fear of falling. So we've talked about in terms of screening, they're still recommending the Falls Efficacy Scale International or the Short Falls Efficacy Scale. So those tools are freely available. That's the Falls Efficacy Scale International. So it's got 16 questions and gives you a range so you can work out if someone's got low concern or high concern. And that's the short FESS, so that's 7 items. So, it doesn't have to take a long time to assess for fear of falling. The short FESS misses some of the sort of, instrumental things like ADL, so like cleaning houses and things like that. But yeah, still gives you a good idea, and it's quick if, we're trying to incorporate it into our busy sessions. The other considerations, there are quite a few screens out there. So you might also need to screen for anxiety and depression, consider cultural implications as well. You can look at carer perceptions. It might depend on the healthcare setting that you're in. And there are some condition-specific screens as well. There's some literature, especially around Parkinson's, MS populations as well. Or at least you could start with asking the question. So are you concerned about falling? So you could ask a Likert scale. So to, not at all to quite a bit. And at least it gives you a start to work out whether you actually need to go on and use one of those tools. But it, actually addresses that factor. So some quick interventions. So it's working as per usual to address those modifiable risk factors. Balance and exercise should also include the physiological and psychological factors. It's recommending all the usual things like vision reviews, environmental assessments, lots of education to not only the patient but their families as well. We'll hear about CBTs in a minute. Again, multi-disc approach. There is some evidence around hip protectors increasing self-efficacy, possibly Tai Chi, but it's really working with that patient to provide the reassurance and work with them to understand what will make a difference for them. You've got referrals. It's making sure any of those other factors like depression are treated as well. Other practical strategies, so again, just encouraging activity and function and actually showing them that vicious cycle about why that you are looking at this and why it's an issue. Not many older people realise that that's, they think that they're not moving, so they're being careful, but they don't realise by being careful, they're actually increasing their risk of falling. So you need to actually spend time on that, on providing that education. Group conversations, some stuff around peer-to-peer learning is good. Encouraging correct techniques. A lot of the fear of falling is also around transfers. So, sitting to standing. Getting in early, as we know, the sooner we can address this and nip it in the bud, the better outcomes for the patients in terms of that, reducing that functional decline. Looking at working out, what you can do to support them using grading, for example. So, short chunks, what can we do to actually address this in a way that's going to work for that patient? We've talked about falls action plans before. So that's part of so if you are going to fall, what's going to happen? How can you get off the floor? How are you going to get help? So sometimes actually having a plan in the place can reduce that fear as well. There's also relaxation strategies, so learning how to manage that fear. That you could look at depending on the patient. And there's other practical things like, are they sleeping? Are they eating properly? Are they using any alcohol? All those things as well that you need to explore. So can we make a difference? We can, and we need to get in early. And these are just some of the patient's perspectives. So, I've had a fall, I've landed on my knees, I've lost my confidence. The equipment helps, but it doesn't restore your confidence, where sometimes we think by giving equipment, we can, help with confidence. Just about people's different views on risks, and an older lady who, had lots of falls, had bruises and injuries, and didn't want to go out because she was embarrassed by the way she looked rather than sort of fear of falling. So it's really getting down to what's actually causing that fear and why they're restricting the activity and what you can do to support them.
Thank you so much, Christy. Our next speaker is Ian Holbrook. So Ian's a part of our team at Injury Matters, and he'll be talking about cognitive behavioural therapy and its use for falls prevention. So Ian started his career as a police officer for Walpole, leaving to commence full-time study at Murdoch University in psychology. As an early career psychologist, Ian worked in the drug and alcohol sector before moving into commercial EAP, or employee assistance programs, and then undertook a number of contracts with organisations such as Shell, Chevron, CFMEU, Department of Veterans Affairs, WorkSafe, and Department of Justice. Ian has his supervisor's endorsement, successfully supporting new psychologists to achieve registration status, and is passionate about ongoing learning and professional development. Ian is a musician, spending apparently far too much money on musical instruments to play in a number of bands here in WA. So as well as being a registered psychologist, Ian is also the general manager of our recovery support team at Injury Matters. Welcome, Ian.
Awesome. Thank you very much, everybody. I just need to press this button to move through slides. Is that correct? Let me have a try of that. There we go. Look at that. Brilliant. Got a few little things I need to keep handy here throughout. Just bear with me a moment. Whilst I go through my slides today, I realised I'd made a colossal error on one of the slides. So it's your job, if you can spot the error. There's a prize here. It's some little road trauma support toy and air freshener for your car on the way home, so you have the beautiful smells on the way home after the event. So whoever spots it first, sing out. Don't be shy. Interrupt. It's not this one, by the way. So. It's not too far into the presentation, and I'm sure the eagle eyes here in the audience will spot it. So here we go. So I am going to talk a little bit about using cognitive behavioural therapy. I've come at it from the lens of a psychologist, and I'm aware I'm in a room full of people who are probably more expertise in terms of human movement, supporting people returning from various injuries and so forth. So if I go off course, feel free to let me know around that. But obviously, we've covered, I guess, how falls can increase the level of avoidance that somebody has around activity, and engaging in exercise programs, and also continuing to walk up and down stairs and put themselves in situations that may or may not be perceived as dangerous for them. So it becomes a vicious cycle, and we don't want to allow that to go on for too long. So obviously one of the things we want to do is identify that early on. And from what I've seen in situations where people have something that's a barrier to them achieving things, there's a reluctance there to speak about it and bring it forward. So creating a culture and an environment where that's safe to explore that for somebody and have those discussions is really important. I'm aware that some of these slides might cross over on the last presentation, so I'll probably move through a little quicker as well. So what the area I want to talk about mostly today is about what habituation is. We want to target those cognitive distortions, those thoughts that don't really match the reality of someone's capacity. And habituation is about creating a habit that we've all got of different types of habits. There's good habits and bad habits, but the good habits are the ones that keep us moving, keep us engaged in something, so that something as simple as walking up and down the stairs, we don't second guess it. It's an autonomic response. We know we can do it when we're moving around on our daily lives. But for somebody that's had an impactful injury or a fall that's occurred, that can certainly change. And then there's that point in time when they stop themselves and they assess the situation, obviously engaging in that negative thinking. So we want to confront that fear in a controlled way, a systematic way, and breaking things down. Reducing that emotional response, which is really important, so that we're not creating the hyperarousal that was brought up in the last slide, where we're engaging in the fight or flight, and that the nervous system is kind of going to get in the way for us, and all of those adrenal responses that we're well aware of that can occur can reduce quite quickly over time if we are able to intervene in the right way at the right moment. And I'm going to let this slide linger a little while. So there we go. Winner at the back. What's wrong? Oh, is that good spot? That wasn't why I knew this slide was wrong. But if you look at the way that the concentric wheel goes around, through gradual exposure, then it moves to cognitive restructuring. That's okay. But then from experiments, we're moving to positive enforcement back to the exposure. I think the wheel needs a little bit of a shifting around there. Come and collect your prize at the end. I'll give you that for spotting the spello. Are you a school teacher? No? You've got young children in school? No? Oh, there you go. So I've got Grammarly to help me out. So it obviously didn't pick that slide up for me, unfortunately. So that's a general cycle, and we want to create that gradual exposure to the stimulus that's creating the fear or the concern, as we know now, that we refer to it with the client. At that point there, we want to engage in a behavioural experiment that demonstrates to the client that they can achieve something that's going to be difficult, that their fear is restricting them from doing. So it's really important that that behavioural experiment is designed in a way in collaboration with the client as well, so that they can tell you, oh, I think I can achieve this, but that one's probably a bit too far. Okay, so what's in the middle? And those type of negotiations are really important to allow the client to have control about how that moves forward for them. It then gives them that sense of ability that they can decide what they can achieve as they move forward through the process of discovering that they can re-engage in some of those activities. And then obviously the positive reinforcement comes at the end. That's the consolidation point. That's where we're going to really nail home the habituation of something that someone's engaged in. I'm going to do a little bit of a demonstration shortly. But obviously here, incorporating CBT with an emphasis on the habituation into falls prevention provides a dual approach, addressing both the psychological and the physical dimensions of the falls risk. So we're empowering the patients to face their fears. We want to reduce that avoidant behaviour, which is eventually going to overall improve the quality of life that somebody has if they're engaging in the activity. And the one I've picked today, obviously, was stairs. And wonderful Mary. We're going to guide Mary through a gradual exposure process. We're going to help her to challenge her cognitive distortions. And obviously, at that point in time, we're developing the physical recovery from falls prevention. So I'd like to introduce you to Mary. Mary's here today. She's not really, is she? It's quite obvious. So Renata's kindly offered to be Mary for me today. And I've got a little bit of a process for Renata to follow along to. And this is just to give you some ideas around how, as a psychologist, I approach certain types of dialogue and the way I might frame questions and how I'll look at certain things. One of the most important things and one of the most successful indicators of success in a therapy session is building rapport. Mary and I have had good chats, we've had discussions, we've completed some tests, and we have an idea around her level of concern around falling. But along that way, I've got to know who Mary is, I understand her life. She's told me some wonderful stories about some of the great things she has achieved. But now she's reached this blockage, this point, she's had a terrible fall at some point in time, and she's really quite concerned about engaging in steps at this stage. By showing empathy in that process, I've created rapport with Mary, and there's a level of trust there to engage in the process that we're going to go through. We're going to challenge those cognitive distortions, and I've just got to flip this up for me just a moment so I can read it correctly. There we go. So when I've had a discussion with Mary initially, when I've said to her, how do you think you will go if you were to attempt to try and climb some stairs? She would initially say to me, I'll probably fall. So that's her belief system right there, and we need to challenge that. And through Socratic dialogue, we can explore that. So do you really feel you will fall every time that you walk up a set of stairs, Mary?
Well, probably not, but
A small shift away from it being an absolute to there being some area there that that's what we're going to hone in on. So what might it take for you to be able to engage in stepping up a step? Yeah, absolutely. And would perhaps a smaller step help you to begin with?
I'll definitely.
Any kind of other supports that you think might be useful?
Oh, I'd like to hang on.
Okay. So a rail perhaps, or a handrail?
Yeah.
Because what we don't want to do, we don't want to hold Mary's hand in the process, because if Mary hasn't got somebody there with her all the time, Mary's not going to go up the stairs. And she might not feel confident enough to reach out to somebody and say, hey, excuse me, can you help me up these stairs? So we're identifying things that can be used. Obviously a handrail, and if we were to find a places that she wants to go and visit, generally most places are going to have handrails, and she's going to find out really quickly when she identifies those are the ones she can go to. What are some of the benefits that you might get from being able to use stairs safely, Mary?
Not taking. Friend that I had, she's a small block of units, and there's a
Brilliant. What a great achievement would be for you to visit your friend. So there's the opportunity for us to really lock in something that means a lot to Mary. She hasn't visited her friend. So this is all the buy-ins, and this is going to encourage Mary to take that extra step, to be willing to take on the challenge of being in that space of stepping up a step, facing her fears. And it's really important that that's something we lean on at the beginning, to promote her ambitions, but also at the end as well, when we're talking about creating the habituation, when we're reinforcing the success of what we're about to engage in. Obviously, we've got the scales that we can assess and we determine that somebody has got a fear of falling, but what we don't want to do is return to that at the time when we're doing the CBT. We don't want to use the word fear. So I might incorrectly say, oh, how fearful are you of using stairs? Initially, then I'm saying to somebody, don't think of a black cat. You all just did. The worst thing you can do when you're teaching a young person to ride a bicycle is say, just watch out for that one tree over there. Guaranteed that little person's going to ride that bicycle because they're going to focus in on it. And we all know when riding a bike, whatever you're looking at is generally where you're going to end up as well. So you might come to Mary and say, so if we were to try and step up the step that we've got set up here today with the guardrail, you can all see that there, the nice handrail. How successful do you think you'll be at attempting to step on that step today, Mary?
Really
All right, so that's a 3 out of 10. And that was my bad there, not mentioning the scale. Really easy, out of 10. I know the Leichhardt scale gives you the breakdown, but everybody knows a scale of 1 to 10. Super easy on the hop, and you're in a care situation, you're in a hospital, you haven't got time to go pulling out extra bits of paper and filling out exams. It's 1 out of 10. 10 being most successful, 1 being very unsuccessful. So her belief system's quite low at this point in time about being successful at stepping onto the step. But we're using the word successful. We're not using it in the other way around and saying, how on a scale of 1 to 10 likely are you to fall if you try and use this step? We're planting that negative seed. We don't want to do that. So it's flipping it around. What we want to do then is say, that sounds like a great experiment that we've set up today, Mary. We've got the small step, we've got the handrail. You're willing to give it a try. But I know you're a little bit anxious about doing that at the moment. So let's do some deep breathing to just bring down that parasympathetic nervous system. Let's reduce the arousal so that we can actually attempt to do this. Now, one of the easiest ones, the most common ones out there is box breathing. Who's heard of it? Oh, there you go, probably 50% of the room. So it's one of the easiest ones. First responders will use it, the military use it as well because it's just real simple and really quick. The way I like to help people to understand how to do it is simply, you're creating a box, you're breathing for 4 seconds in, you're holding for 4 seconds, you breathe out for 4 seconds. You hold again, you breathe out, you hold again. So we'll do that quickly just to demonstrate, and I'll go through with Mary. We're going to do our box breathing, Mary, that we've been practicing before this event, obviously. So I'll get you to go with me now. 1, 2, 3, 4. Hold, 2, 3, 4. Breathe out, 2, 3, 4. Hold, 2, 3, 4. Breathe in, 2, 3. And we keep repeating that, probably 3 or 4 cycles. How do you feel now, Mary? Ready to take on the opportunity to step up to the small step? Brilliant. Again, using that opportunity. This is an opportunity, and we're really using those words. Use words that the client uses as well. It'd be a great opportunity to be able to see my friend. So we'll replay those words to her. So now, Mary, I invite you to attempt to step onto the step, and perhaps even to begin with, you might just want to put your foot on there and step off again. So we're breaking it down into even more smaller, achievable, measurable goals. These are really small incremental things. The type of exposure therapy is what we're engaging in. Say if someone was afraid of a snake, I'm not going to bring a big boa constrictor in the room and go, there you go, come on, don't be fearful, do some box breathing. We might show them a child's book photo first, and then an image, and then perhaps a soft toy, and then the little squirrely rubber snake that we can use. And then we'll go to the shopping centre where you get old Albie Mangles look-alike with the snake wrangler, and we might just observe from a distance. We might visit the zoo and go through the nocturnal area and look at the snakes. But the more steps you can put in between actually reaching the event, the less likely you are to create a situation where it's beyond their reach. So, for instance, Mary today is all simply she's going to do some weight shifting, moving onto the step and off. Go at that for me, Mary, and see how you go. Yeah, that's fine. Bit of weight shifting. You're doing really well. And when you're ready, just see if you can just place your foot on and tap it off again off the step. Brilliant, nice work. Yeah. Let's have a go. You're doing so well. Why stop now? Do you feel comfortable to perhaps even take a step up onto the step? I said to Renata, I said, you feel free to throw some curveballs, you know, make it more dynamic on the way. You go on and off. Fantastic. Well done, Mary. Round of applause.
Which one do you want to?
Yeah, that's it. Yeah. So we've identified the fear, and that's done in the early stages. We're challenging those unhelpful thoughts. So when she says it's an absolute that she will fall, then we challenge that. Is it really an absolute? 100% every time you're even going to try that. Nobody's going to be an absolute. You're going to move through to engage in the exposure component and gradually desensitize them to what actually may be going up those larger steps. Reinforcing the success, super imperative. Stay in this stage for at least a third of the time that you spend doing all the other areas. This is where the habituation takes place. So I will ask more questions around, how did that feel stepping onto the step, Mary?
Well, I did it.
You did it. You did really well. And I understand that when I asked you previously how successful you might be being able to step on the step, if you were to think about that again now, how successful do you think you would be about being able to step up onto the step? 7, great. So that's what I'm going to lean on that even more. A 7, that's amazing. That's such a big change from a 3 to a 7. You've gone up all those points. That really says to me that you're on the other side of this now. It says to me what you're able to do now is to assess that risk a little bit more realistically and demonstrate your abilities to step onto the step. And I'm just going to keep on layering on all that positivity, that reinforcement, talking about how all those opportunities now, even though it's only one step. You did mention earlier that the spice rack was a bit high at home and you haven't used your little stepper to go up and be able to make that meal that you really enjoy making for everybody. So we're finding all those buy-ins along the way, all those opportunities to layer on and reinforce the success really that we are achieving. Now, get my iPad to flick up. So we're linking that to the opportunity really, and that's the long-term strategy, is to get her to be able to engage in walking up the steps to go and see her friend. So we can use, you know, cheesy language like, wow, you're one step closer to being able to go and catch up with your friend now. And it's neuro-linguistic program in a way. It's all positivity, and we're always linking it back to that opportunity that's going to give that enhanced sense of life for Mary down the track. We are creating a habit because Mary now has challenged her own cognitive dissonance around there being a 3 score. How successful? Well, you were a 7. So I would suggest sometimes, Mary, that you perhaps embellish on the concern that you have around steps. And perhaps we need to factor that in future when we conduct other experiments, and perhaps we'll go up the set of 3 stairs that we've got available to us in the future. And you can reflect on this today and consider that your concerns around those stairs aren't actually as deeply embedded as maybe they need to be, because your abilities are far better than what you perceive. Again, I'm staying in that space, I'm reinforcing it, it's positivity. And that's really important, that habituation. What we want to do then is to repeat the experiment as many times as we can. I understand people are time poor in those settings as well. So we do the best we can with the time that we have, but you can fast track it by just not getting too caught up in the administration side of things. Don't have them fill out too many long testy questionnaires. Just get right to the core root of where the fear lays, identify it, incremental experimentation, quick scale of 1 to 10. How successful may you be? It's low at the moment. Right, let's expose you. Let's get you doing that small incremental step, get the wins on the board, and then layer that on as we go through. It's normalisation is another word for it as well. It's extinguishing the fear along the way. So then, Mary, who was afraid of using stairs after the fall last year, this fear has led to her avoiding stairs altogether, significantly impacting her mobility. As you can see, Mary was able to step up the 1 step. And she's moving quite well now. All that exercise physiology is coming home to roost.
Thank you very much, Ian.
And I guess, sorry, I'm Rachel, General Manager of Injury Prevention at Injury Matters, moonlighting as a terrible photographer tonight, so I can guarantee none of those photos will be used. Thank you so much to Ian, Alyssa, Marianne and Christy for sharing your knowledge and insights for our audience here today. Thank you, Mary, as well for your acting skills. I just wanted to quickly wrap up this evening by saying, as has been mentioned already, Injury Matters through the Stay on Your Feet program have a variety of resources that you can access to use with your clients. If you don't already, you can visit our website and you can order bulk resources that we will post out to you for free. And in your pack today, there is some examples of the Up Off the Floor resource, which is useful for guiding your patients and clients through how to get up off the floor, as well as a variety of other resources. So please, we encourage you to access them. I've been asked to really push. Can you please fill out the evaluation form? It should take 30 seconds within the pack, or if you want to do it online, there is a QR code on there. Hopefully we didn't put any IT questions on the email, because we're well aware that things haven't gone to plan as we had hoped. So thank you again for your patience while we navigated them, and to the people online, we hope that you are able to view this in the coming days when we're able to get that out to you. We will share with you the recording, and those of you that have requested a certificate for your CPD, we will make sure we get that out to you in the coming days as well. Also, just to continue the conversation, in case you're not aware, we have a Community Falls network which meets quarterly to provide people such as yourselves who are working in the space of community falls prevention a space to share learnings and solutions related to falls. Our upcoming meeting is on the 19th of November, sorry, skipping ahead to February already. But if you're interested in joining that, please reach out to us. Suzanne leads that group, and we welcome new members all the time. Finally, I guess having wrapped up, I wanted to talk quickly about Injury Matters as an organisation more broadly, as we are moving into a new strategic period for the next 4 years. We've outlined what we see as our pillars for success moving forward to 2028. As part of that, we have outlined an aspiration, and that's to extend our reach across Australia to reduce the impact of injury. And to do that, we have 3 commitments. That's to take an equity-based approach to our injury prevention and recovery services, to maintain our robust approach to quality and governance, and to continue our commitment to cultural safety through advancing our Reconciliation Action Plan. As part of this new strategic period, we've outlined, I guess, 3 pillars. I won't focus too much, while they are important, around growing our financial sustainability and developing our and empowering our values-based team. The area I wanted to really talk about is our positive impact on injury outcomes in Australia. To achieve this, we are focusing on enhancing our public profile. We're focusing on informing the public about the impact of injury, because we know that there is a gap between, I guess, attitudes and awareness towards the preventability of injury. We want to build clear and accessible pathways to access our programs and services, and we want to build momentum for injury prevention and recovery across all levels of government. And finally, continue to create strategic partnerships to support our purpose. As part, I guess, building on that, building momentum for injury prevention across all levels of government, one area I wanted to touch on is the falls guidelines, which I think a couple of our speakers spoke about today. So the updated falls guidelines is the national guidelines, now open for public consultation. So we invite you to provide feedback on the draft guidelines. They're tailored for 3 key settings, being residential aged care, community and hospital. So if your organisation engages, I guess, in contributing to this sort of consultation, please take the opportunity to do that. They're closing on the 24th of November. The other thing I wanted to quickly touch on is we've talked a lot about today about the impact of falls. We know from the falls report the cost that falls has on the West Australian community, but there is significant underinvestment in prevention of falls across Australia, I will say. And there's an opportunity upcoming with the upcoming state and federal election for us to make a little bit more noise about the need to focus on healthy ageing and falls prevention. We know that the population aged 65 and older is going to increase significantly over the next few years, from 16% to 19.5%. So we really need to scale up evidence-based falls prevention activities. Based on the data that we see through the falls report and the subsequent recommendations that we make in that report, Injury Matters has prepared, I guess, our election priorities. This is what we are advocating to the state government that we would like to see, which includes funding the delivery of a specific Aboriginal falls prevention program. So we know that older Aboriginal people are impacted by falls, and there is a lack of culturally appropriate falls prevention programs. There has been research into effective interventions, and we would like to see funding associated with that. We would also like to see increased funding for falls prevention mass media campaigns to raise awareness that falls are preventable. Again, despite the impact of falls, we really don't see that investment equivalent to other preventative health public campaigns such as road safety. So yeah, we would like to see increased mass media funding. And finally, we've talked a lot about the effectiveness of evidence-based exercise interventions for falls, and there is significant gaps in terms of accessibility to those programs within the metro area, but really in regional areas of Western Australia. And so at Injury Matters, we would like to see investment. We know that they're cost effective in preventing falls, and it can be achieved through the introduction of low-cost programs that can be delivered within local government recreation centres, as well as subsidising classes for older adult clients within private clinics. If, I guess, this rings a bell to you, I would love to talk to you more about this and how we can collaborate to, I guess, have a joint voice in terms of falls prevention advocacy in Western Australia. Just another quick slide in terms of upcoming events. Injury Matters has a variety of events. If you were interested in and took a liking to Ian this evening, he'll be hosting a webinar for people affected by a road crash. So that's about understanding road trauma and the services that are offered. We offer a family and domestic violence awareness training. So if you work with clients that you suspect might be at risk of family and domestic violence, this training will help build your knowledge and skills in how you can support and refer these people. We have an alcohol and older adults webinar, which will be coming up towards the end of the month, as well as our arthritis, osteoporosis and falls webinar, which will be delivered by Professor Anne-Marie Hill towards the end of the month. And finally, we will be collaborating with the Public Health Association to deliver the Public Health Pre-Election Forum. So if you're interested in any of those things, sorry, the slide's gone off the bottom there, visit the Injury Matters website. Just finally, one last thing I wanted to say, I know we've gone way over. Injury Matters has received funding from Healthway to deliver the Older Adults Preventing Harm from Alcohol and Other Drugs pilot project. This is a project that is targeted at allied health professionals, so those of you that are in the room here, and providing free training in how to identify older adults who are at risk of alcohol and other drug harm use. So it will be training people in the Assist Light tool. The training is delivered as 2 half-day workshops. So it'll be on a Wednesday and then you'll have to come back the following week as well. Sorry, not just a Wednesday, but you have to come back the following week for the other half day. The events are going to be held in February and we're going to be hosting them throughout Perth as well as in Bunbury as well. So I guess this is an opportunity for you who are working with older adults. We know that older adults drink at riskier levels than any other age group, but there is lack of, I guess, interventions targeted at this audience. Often we focus on young people when it comes to reducing alcohol-related harm. We've spoken about medications a bit tonight as well and the interactions with alcohol, all places people at risk of falls. So this is an opportunity for us to address that in a different way. I think that's everything. So thank you so much. Thank you for your patience again tonight and drive safely.